Well, thanks, Murray. It is good to be back, and it is good to be working for the speaker. It's quite amazing when you move from working for the minority leader to the speaker. All of a sudden, you become a lot more popular. What can I say? But life is good, and we have to thank California. I mean, it's a little surprising to me that Orange County went blue. The number of Republicans in this state elected to the House went from 14 to 7. I don't know what that says about the future, but so what I'm going to talk about today is how do I move this? Do I have the right one? Thank you. For the prescription drug, the need for lowering prescription drug prices. And I'm actually fairly optimistic that Democrats and Republicans can get together and take some significant action in 2019 to lower prescription drugs. This is a forecast conference. That's my main prediction. And you can judge me next year to see if we do it. So these are some factoids about the need for lower drug spending. Between 2008 and 2015, prices for the most commonly used brand drugs increased 164%. In Medicare Part D, 10 drugs with the highest spend accounted for 21% of all Part D. I could also mention insulin, where the cost of it doubled between 2012 and 2016. I think it tripled over the last decade. So there's lots of factoids that point the need, and it is also on the minds of consumers, Americans, and the Democrats ran on lowering prescription drug prices, doing something about wage stagnation, and cleaning up corruption in Washington. Those were the three main areas. So why do I think we can get to a deal on drugs? The number one issue is the administration, and it's trying. I think President Trump has his health advisors working very hard to cut prescription drug prices. But the truth is they do not have the legislative authority to do it. So if you look at the two main proposals that they have advanced through regulation, it is basically getting rid of rebates. Well, what did the Office of the Actuary say about that? The Office of the Actuary said taxpayer costs are going to go up about $200 billion, and drug spending is going to go up $137 billion. Because what the Office of the Actuary said, if you take away those rebates, prescription drug prices may come down a little bit, but they're not going to come down nearly enough to offset the loss of the rebates. And the only thing the administration can do is say please, or bully, pulpit, or jawbone. They have no authority right now to actually force the manufacturers to lower list prices. And I could also look at their Part D, B as in boy, proposal. I think the problem with that is I don't know of any vendor who's going to step up and basically say, oh, we can get enough price concessions from drug manufacturers so that we can compete or sell these drugs at the International Price Index. I don't think that's going to happen. I know the Democrats and my boss, we would like to work with the administration, and there's something in for collaboration. The main thing is we know what the drug manufacturers are going to say. They're going to say we're cutting drug prices that will hurt cures, innovation. That's the arguments we're already seeing. And if both parties go off the cliff together, they can't shoot each other come the next election. And that is the real advantage to trying to work together to achieve lowering drug prices. And I think from where we're coming from, we want CBO to show significant savings. So we're not talking about just getting rid of that interference clause in Part D. We're actually talking about doing things where CBO, as an independent validator, will say we have lowered prescription drug prices. And then we want to take those savings and plow them back into Part D. Now, Bill mentioned the discretionary caps. I think the other thing, I know the House staff is all united in this, to fix the discretionary caps is a $2 trillion cost, because we don't just get scored for 2 years, we get scored for 10 this time around. And whatever we would do on prescription drug pricing, while it may be significant, 60 to 100 billion or thereabouts, it is a small dent in the discretionary. And there are plenty of places we can put those savings to actually lower cost for Part D. So I divide this into 3 buckets, if you will. The low-hanging fruit, those are things like the Creates bill, the Pay for Delay bill, getting more biosimilars into the market, maybe an inflation rebate in Part B, some product copying, some patent changes, et cetera. And I would expect the House to start to move those in the April to June timeframe. And actually, just to show how bipartisan this is, the new chairman of the Senate Finance Committee, Chuck Grassley, has written the strongest Pay for Delay bill in the Senate, as well as the strongest Creates bill. So there is clearly bipartisan support for many of these things. Then the big enchilada is, I'll say, the Democrats' favorite word when it comes to drug pricing negotiation. What does that actually mean? And we have been working, the staff, have been working on that for 3 or 4 months now. And, I think it is going to be a shall. The secretary must negotiate. We're going to give the secretary some flexibility on exactly what drugs he can go after. Maybe the one where we spend the most money, Humira, $16 billion a year. Other very high-priced drugs, especially the specialty drugs, the sole source, and say he must negotiate on at least 20 to 30 each year, a floor. He can pick more if he wants. And then you'd enter into a period of what I'll say is voluntary price negotiation. And if they don't agree on a price coming out of that process, then you go into what I'll say is a baseball-type binding arbitration. Now, it's one set of rules. There's other ways of getting there, too. And by baseball negotiation, I would say then an arbitrator picks between the two. That gives an incentive then, if you can pick, there's many different ways of doing arbitration, but if you pick somewhere in between, then pharma and the secretary have an incentive to go to the opposite ends. Whereas if they know it's either going to be the secretary's bid or the drug manufacturer's bid, they tend to cluster more into the center of the distribution. So that's one possible way. And I think it's going to take some time to educate members about all of this. One other factoid I'll put on the table, 58% of the Democratic caucus was not around when the ACA passed. And I think that percentage is actually higher on the Republican side. So there's lots of education, and this is one complicated market to try to explain what you're doing, et cetera. And then the third part is Part D, and I read Joe Antos's testimony, very good testimony to the Ways and Means Committee, I think last week, where he and I agree on a lot of the things we should be doing in Part D. We need to revise that program. We need to put an out-of-pocket limit. As you can see here, in 2007, about 400,000 Part D beneficiaries got into the catastrophic coverage limit. Today, that's more than doubled, or 2.5 times, if you will. And you can take one medicine and basically be above the catastrophic threshold. And these are the kinds of drugs that we would probably concentrate on in terms of trying to lower prices. So the main point here is we know we can make changes to Part D. We know we can lower the cost to the elderly beneficiaries significantly if we plow those savings back into Part D. And there's other changes that MedPAC and the administration have put on the table that I think Democrats can agree with or do agree with. So that's number one, very optimistic. Then I will turn to coverage for a minute in the ACA. I think there's been a lot of sabotage of the ACA and Medicaid. We've had the individual mandate repeal in the tax bill, as you all know. I do not, in this area, do not see us moving forward at the federal level. I think there's a lot of opportunity for states to move forward. I think you're going to see Medicaid expansion. Even Georgia is thinking about it, and Oklahoma are thinking about it. So I see a lot more action at the state level in terms of Medicaid expansion and maybe also the work requirements, which I think are just throwing, just hurting enrollment. I don't think there's nothing to work requirements that's actually helping those people find work and move into the labor force. I think it is primarily about putting administrative barriers in front of them in terms of getting Medicaid. Various also states have taken away retroactive eligibility. There's about 7 million people in this country that are eligible for Medicaid but aren't participating. In some ways, you could say they have insurance. They don't have that insurance card in their back pocket, but if they went to the hospital, those charges would be covered to some extent by the Medicaid program. And I think sabotage has really started to do something. We hit a low of 10.9% of adults being uninsured. That has now ticked up. This is from the Gallup poll. That same phenomena has been documented by the American Community Survey in the last census as well. So there's multiple sources for the fact that sabotage is really starting to hurt coverage. I think the ACA did slow down. I think Bill or someone mentioned this. So in private insurance, Medicare and Medicaid, the cost per capita have slowed significantly, and that's not all due to the ACA. A lot of other factors were at work here as well. I'll tease for the panel this afternoon. This comes from Joe Thompson, where it really is a remarkable story in Arkansas, where you had Governor Beebe work with a Republican legislature, was the first state in the Deep South to expand Medicaid. They cut their uninsured rate in half. So it really was bipartisan success. And then we had the election, and now Medicaid rolls have fallen by 60,000. Providers are dissatisfied, and I think there's roughly been 18,000 or more that have lost because of the work requirement. And states can act. They can restore the individual mandate. They can do risk insurance. They can start to cover people in the 400 to 600% of poverty. And that's essentially what I understand Governor Newsom is about in this state. So he can set a very good model for the rest of the country, assuming the California legislature moves ahead, and you'll hear more about that this afternoon as well. What happens after drug pricing? I think we will address the problem of surprise billing, and I think there are other efforts to lower healthcare costs. Those are more complicated. There hasn't been much attention onto those, but there are other things we can do to slow down health costs. The opioid epidemic still remains a top priority, and one of the things that Democrats in the House really want to do is do various things to reduce gun violence. I'm going to skip this slide. This is one of the ways Marty McCary, Shannon Brownlee, and others have talked about that we're overtreated in some instances. I think there are providers that are still out of bounds in terms of clinical practice. I think they need feedback. And I think when doctors get that feedback, they will change their behavior. Here's, for example, again from Marty McCary. Best prescribing practices suggest that the number of tablets per adult should not exceed 10, and yet we've had the case where many providers are doing much, much more than that. I will continue to say that this country is not getting ready for the retirement boom. The spending on people over age 65 increased from 35% of non-interest spending in 2005, and we're going to hit about 50% in 2029. In terms of outlay cost in the elderly, we're going to increase from 6% of GDP to a little over 10%, and that's purely because of demographics. It's the number more than anything else. And I think the tax scam, the tax bill set us backward big time. So I actually think I don't think we can afford to extend those tax cuts. Bill is right, we're gonna make those decisions down the road. But I think at that time, we will be really into the baby boom. The baby boom will start to be turning 85, 90, the long-term care cost, et cetera. I think that is going to make extending those tax cuts more difficult. I think there's an agreement, and my last thing is agreement in the Democratic caucus on the importance of universal coverage. And I would argue that the most effective platform for moving closer to universal coverage is basically by building off the ACA. The Democratic Party is divided on that score right now. I know the Speaker is firmly committed to building off that because it is the least expensive way to do that. You've heard a lot about single payer, and I will just say a couple things. I get myself into trouble every time I say something about this, but I think it is the truth. And many of the senior Democrats also believe and understand that. So it's not just one reform. It's multiple major reforms all at the same time under this heading, Medicare for All. So what is it? It makes major provider changes in terms of reimbursement. The California Hospital Association tells me that commercial insurers in this state pay 2.2 times Medicare rates. In Northern California, it's 2.5 times. So you're not going to take a rate of 2.5 or 2.2 and take it down to 1. You would also take some Medicaid rates up, big time in this state, et cetera. So think about that. You're going to be transporting a lot of money from the north to the south, from the suburbs to the inner city. And that kind of redistribution is not going to take place. It's the thing that dogged us the most when we were doing the ACA. The regional issues about the transfers of money that were involved are enormous here, and for that reason, I don't think it's going to happen. Then it makes major improvements in Medicare. It puts an out-of-pocket limit in Medicare, it standardizes or modernizes the cost sharing, it adds vision and dental and hearing. That by itself would be another major reform. And then the bill that will be introduced next week, I think either Tuesday or Thursday by Representative Jayapal, will also add long-term care. There's a lot of simplification in terms of less cost sharing, better coverage, less out of pocket. And then the last reform it's doing, it's moving all of the employer health care costs basically onto the federal budget. So there are experts on the right and the left, Chuck Playhouse, the Urban Institute, have said that all of that is about $32 trillion. And that probably is an underestimate because the Urban Institute didn't take account of the latest changes to the Jayapal bill in terms of long-term care. So for all those reasons, these bills have not been defined in terms, I can argue that every hearing we do on healthcare this year, I say this a little tongue-in-cheek, will be a Medicare for All hearing. One little part of it is doing something about prescription drug prices. Well, that's what we're going to be about in terms of detailing exactly what that means for probably most of this upcoming year. You know, and then there's a lot of talk about improving Medicare, Medicaid, and Social Security, and Medicare does have some out of limits. It doesn't provide all the essential health benefits. It does set prices, but it doesn't do many of the cost controls that Medicare Advantage plans do, for example, and it doesn't have an out-of-pocket limit. Kaiser Family Foundation says 80% of the elderly have supplemental coverage. So we could put an out-of-pocket limit in, we could improve Part D, as I've already talked about, we could add vision, dental, and hearing. We could ensure that the COLA increases in Social Security are not consumed by the Medicare premium increases. We could improve benefits for frail elderly. Congressman Larson, who's chairman of the Social Security Subcommittee, has a bill that has a 2% across the board increase in Social Security benefits, relieves elderly of a lot of taxation of Social Security, and has some other major improvements. That bill by itself is raises taxes by $18 trillion. It's a little hard to comprehend, but that's a present value 75 years. So there are lots of ideas here on how we can expand Medicare, Medicaid, and Social Security. I think all of them are not going to advance very far, and really the country, I think, has to have a discussion about which of these are the most important. I personally would put I think we ought to do something about long-term care. I mean, it's going to have huge implications for Medicaid programs in the future. I don't think it's gotten nearly the attention it should, but we are going to have to find some way to finance that benefit. The opioid epidemic still remains a top priority. I think we're basically maybe just starting to change that epidemic a bit in terms of having death rates fall, but I think we have a long, long ways to go. The Kaiser tracking poll, when asked to choose a top healthcare provider, 51% of Democrats indicate that Congress should focus on improving and protecting the ACA, while 38% choose Medicare for all. And then if you ask, go deeper, do you favor or oppose having a national health plan? 56% to 42% favor it, 42% oppose. But then when you go deeper and suggest what some of the problems would be, you get very much differences in how the American public views a Medicare for all plan. And the truth is, I don't know how good polling is at this stage of the game when these bills really haven't been defined. And I think focus groups are maybe the only way you can get an accurate assessment of the public's opinion about it. So, in conclusion, my number one forecast is we are going to do something about prescription drug prices. I think we will cut a deal with the administration, and I think that if we do it right in the House, that will give it enough push to get it done in the Senate. I think we can improve and strengthen the ACA at the state level. And my last prediction is those tax cuts cannot survive our country's demographics. So we'll see. So thank you for the opportunity to come back.